Another prosthesis dysfunction is the mismatch. In this situation, the mean gradient is high, although the components of the prosthesis, discs or leaflets, are normal. This is the result of a small prosthesis replaced for the patient's size, leading to an effective orifice area less than 0.85 square centimeter per square meter of body surface area. Then, we suspect a prosthetic mismatch when there is a high trans-prosthetic mean gradient and no structural problems with the prosthesis. Visual aspect of ring circumference is clearly quite less than the circumference of the aorta. The visual orifice of the open leaflets make more obvious the difference with a normal valve opening that would reach the aortic walls. There are no structural abnormalities in the leaflets. The other 3 and 4 items are for those who believe that continuity equation is accurate enough to distinguish between those cases where items 1 and 2 were unable to make the distinction. Look this TEE example. Just by eyesight, we can assume that this sewing ring is quite smaller than the natural ring of the aorta. And furthermore, the native leaflets would open as far as this wall here. Now, taking into account the leaflets inside, the affected opening will be quite smaller, even though the leaflets are opening properly. Its output is not enough for the patient's metabolic requirement, particularly during exercise. Another case, this would be the area of the native aortic valve, and here the area of the valve with a mean gradient of 27 millimeters of mercury, indicating a mild to moderate stenosis, but during exercise it would show a higher gradient. Another case, in this transesophageal short X, it's evident the mismatch. Note not only the smaller sewing ring, but we have to consider also the obvious decrease opening by visual inspection only. Mean gradient also of 27 millimeters of mercury. One more case. Note the relation between the aorta and the small sewing ring, but mainly the valve opening in the transthoracic and transesophageal short X views. Mean gradient was 60 millimeters of mercury. Mismatch is very uncommon with mitral valve replacement. Look at this example. This long X shows the prosthetic sewing ring is clearly quite smaller than what would be the normal mitral annulus. This annulus, for some reason, was pulled anteriorly as to accommodate the smaller prosthetic valve. We can say this by noticing how the posterior basal wall was also awkwardly pulled with the annulus. M-mode shows a perfect leaflet with no calcification and normal opening. Mean gradient is as high as 13 millimeters of mercury. In this TEE, we notice that the prosthetic valve is smaller than the mitral annulus, and part of the native mitral valve remained as fixation for the prosthetic sewing ring. The problem here is that there is enough remaining native valve what make the prosthetic valve to move with more displacement than the native remaining, causing frequent suture dehiscence. As can be seen here, look the mobility of this prosthesis compared to the walls in this long X, since it is not fixed to the walls, but to the remaining of the native valve, as shown by the TEE, what produces constant bending between the sewing ring and the native remaining, with frequent suture dehiscence and paravalvular leak, as demonstrated here with this severe regurgitant paraprosthetic leak.